Good morning to everyone out there that's joining us today for this virtual event. My name is Don Page. I'm Vice President of the ISHE membership here in Indiana, and we're bringing you this event as part of the Midwest Healthcare Conference. And obviously, we have our sponsor, BSA Life Structures, which we'll get to a little bit more information on them later. But I want to welcome everybody here. And as many of you know, we had the Indiana Hospital Association on tap to present at the Midwest Conference back in October, but we're unable to do so due to a topic that everyone is sick of talking about. So for the next hour, we're going to have a Q&A, and we'll be hearing from the Indiana, Ohio, and Illinois Hospital Association presidents about healthcare in 2020, the challenges we'll be facing moving forward, as well as the impact of the election on healthcare in our states. And then we'll have an additional 30 minutes at the end that Brian will present additional information along with Rob McClan to the group, specifically more for Indiana. The speaker today, as I mentioned, Brian Tabor, president of the Indiana Hospital Association. The IHA is the chief advocate and works to represent the interests of the state of Indiana, the federal government, business community, regulatory agencies, and accrediting bodies, along with many other stakeholders of the approximately 170 Indiana hospitals. Secondly, we have Mr. Mike Abrams, President and CEO of the Ohio Hospital Association. The Ohio Hospital Association has a team of more than 50 associates, supports a 20-member board of trustees, serves on a variety of healthcare and hospital task force and committees, and works with the 2,400 members of the 7 OHA-affiliated societies to guide the association toward its mission of collaborating with member hospitals and health systems to ensure a healthy Ohio. The third panelist is AJ Wilhelmi, President and CEO of the Illinois Health and Hospital Association, with offices in Chicago, Naperville, Springfield, and Washington, D.C. The Illinois Health and Hospital Association represents more than 200 hospitals and health systems as they care for their patients and communities, advocating for a sustainable, patient-focused healthcare system that provides high-quality care and promotes healthy local communities. So I want to welcome all three panelists to the event today. But before we begin our session, I would also like, again, to thank our sponsor, BSA Life Structures, and we will now watch a short video from BSA. All right. Thank you again to BSA for sponsoring the event. Now I'd like to turn the presentation over to Rob McClan, who is the chairman of the Indiana Hospital Association and CEO of Good Samaritan Hospital here in Southern Indiana. Rob will be leading the Q&A and provide additional insight into healthcare as we head into 2021. So Rob, it's all yours.
Well, thank you, Don. First, just confirming, can you hear me?
Yes.
Okay, good. Well, I'm trying to work on getting the video up as well, so I apologize for being a black screen of death to everybody. But thank you all for being part of this, and thank you, Don, for setting it up and kicking it off. We want to talk a little bit today about healthcare in both the short term and the long term. So to get a sense of what the similarities and differences are across our three states, I think it's really important. And we cannot ignore, obviously, COVID. So let's start with this panel with a few questions about the impact on hospitals related to COVID and what that means for facility planning. And I'll start with the first question. What do you see your members doing in response to COVID with respect to large-scale projects? Are they being delayed as hospitals focus on smaller projects like, we've had to have new entrances in temporary or pop-up treatment areas? Tell me how you see that working out in your states and across different healthcare providers in your areas.
Let's see. Thank you, Rob, and AJ and Mike. You want me to just go ahead and jump in, tackle this one first?
Dive right in.
Great to see you both, and thanks for having us. I would say, and maybe we can talk a little bit later about some of the kind of smaller projects or maybe new concepts that are out there, COVID response type of projects. But as far as large scale projects, I can't really say for sure how many that are on the drawing board that haven't been announced that might be getting pushed back just a little bit. But we've really seen some pretty significant projects continue to move forward here. The downtown Indianapolis IU Health's large project that's planned is moving forward. Up in LaPorte County in northwestern Indiana, we've got a new facility, beautiful new facility that's just opened there as part of Northwest Health. So really around the state, I do see some pretty significant projects that continue to roll forward at this time.
I would say the same thing in Ohio. Before I get to that, though, I want to thank you for inviting me to participate with this esteemed panel with two of my favorite colleagues. And it is good for me to be back home in Indiana in any form, including virtually. That little speck you see over my left shoulder, it's actually a flattened wine bottle that has the IU logo on it. That's a clock. So I am a twice-degreed Hoosier, and I know Brian's a Purdue grad. So I was one of the few people in the entire state of Ohio that was really strongly rooting for IU over the Buckeyes in football recently. So I was as disappointed as all the Hoosiers on the outcome of that game. But anyway, I do appreciate being invited to participate with this panel. And I would just agree with Brian. We have some very big projects, the Cleveland Clinic, Nationwide Children's Hospital, University of Cincinnati Health, and down in Cincinnati, obviously, Ohio Health, and I'm sure I'm missing out, OSU, Ohio State, Wexner. They've all announced very large projects, a $2 billion tower at OSU. And actually, they have used the COVID experience as part of the narrative to kind of re-up the need for the space that they're planning. So I have seen no evidence that there's going to be a scaling back. I think some of the independent hospitals in our state, and there's still a very robust set of independent hospitals in Ohio that are quite successful. There could be a little more caution among that group, but there are an awful lot of projects that are still rolling forward.
Hello and good morning. I also want to thank Brian for the invitation, and Rob, and to see my colleagues here virtually. Real pleasure to be with you this morning for this conversation. Don't have any degrees from IU, but I do have family that have degrees from Notre Dame. Spent a lot of time in South Bend growing up and had a lot of fun doing So a similar story in Illinois. We are a CON state, so we can track some of these projects and we can compare 2020 to prior years. And while some of our larger institutions are certainly moving forward with projects that have been on the books, we have seen some projects put on hold and some of those projects not move forward based on the COVID experience. Obviously, this is a very, very challenging year for the entire hospital community, large systems, large academics, small independent hospitals, downstate, et cetera. So we have seen some of that activity put on hold, but certainly some moving forward as well. One of the key components, right, of these decisions that are made, looking at the financials, right? And so in Illinois, we did some projections and we saw that the Illinois hospital community in the aggregate was losing about $1.4 billion a month in March, April, May. That kind of, thankfully, we recovered as elective surgeries were allowed to take place again starting after May 11th. There was a 2-month pause on electives. So when you look at the landscape, right, and you look at some of these dynamics in place because of COVID and some of the financial impact, that's probably some of the reason why when we track the projects through the CON process in Illinois, we've seen some falling off compared to prior years, but certainly some pretty big projects moving forward, like in Ohio and Indiana.
Very good. Next question. Many healthcare facilities today are facing kind of an aging infrastructure, which makes regulatory compliance difficult to manage and can decrease patient and staff satisfaction. So how do you see the effects of COVID limiting the ability of hospitals and systems to replace older facilities?
Well, I would say that, and by the way, with all this talk, I need to put my some type of Purdue memorabilia in the shot here. There's too much talk about IU and Notre Dame. Geez. So I'm really intrigued by what Mike said. I think that one of the things that has come up in Indiana, not to jump ahead to policy, but it's woven into kind of what we do. AJ talked about certificate of need, and there has been some criticism sometimes of the industry in terms of capital projects. And I think one thing that's not well understood sometimes is with policymakers or the public, how differently it's delivered. And I think this kind of gets to that question, is that the need for secure entrances, the need for really just safety in the facility, new technologies for cleaning. I mean, all of those kinds of things that sound like maybe to some like they're bells and whistles, they're so important right now. And so I do wonder if it isn't, at the same time there's that financial strain, there isn't a sense of urgency that's created and really might help. I don't want to say the justification, but really moving forward the rationale of some new projects because of the lessons that we've learned in COVID. So I can't say firsthand that folks are, have moved forward with something because of it, but I can see how it could certainly inform decision making.
I think this panel could get very boring very quickly. I think we're going to all be agreeing with each other a lot. But no, I think Brian articulated our situation again very well. I mean, we are seeing a lot of, I would say, curiosity and support for and sympathy for hospitals now among public policymakers, where it might have been a little soft before. If we look at the evolution of how we deliver care and moving patients safely out of the traditional settings and, hospitals at home and telehealth, and those kinds of dynamics will also be an important part of the conversation. In a state like Ohio, and this is maybe true in the other 2 states on the screen, but we are also seeing kind of a outmigration from the smaller towns and rural areas into the 3 Cs, Cincinnati, Cleveland, and Columbus. So just, I look at some of the small communities with hospitals currently, and there has been some evolution of, small hospitals that affiliate with large systems that eventually close their inpatient work and, change the focus of what goes on in those facilities. So I really do think we're seeing an evolution of how and where care is delivered in our state.
I would agree. Again, not to be redundant, but in Illinois, this may be the case in Indiana and Ohio as well, but our regulatory structure allows, grandfathering of facilities for infrastructure, regulatory compliance, so that our hospitals, can continue to operate. That gets a little tricky when there's a change of ownership, because then the new regulatory structure applies. And so there's that piece. Then there's also, the challenge with replacing older hospitals and systems. We have one we call Safety Net Hospital in the Chicago area that would cost about $100 million to upgrade. And so that hospital recently announced it's going to be closed by a system outside of Illinois. And so we see some of that aging infrastructure becoming a real challenge. And what do you do with that aging infrastructure? Do you go ahead and move forward with a $100 million renovation? Do you tear down and rebuild, or do you close? And unfortunately, we've had a number of examples, not quite, into the dozens, but certainly more than a couple, where the decision was made, to close the hospital and to look at how do we re-envision healthcare delivery in that community. And so the system is saying we're going to build an ambulatory facility that will allow for urgent care and the wraparound services and access to primary care, et cetera. This is a conversation we'll get into later in this panel. I think we're having a very significant conversation in Illinois about hospital and healthcare transformation because of the aging infrastructure, because of the challenges from COVID, the financial impact, and where healthcare delivery is going. There's a big discussion taking place with policymakers, with our board, and we have a committee involved as well on this question about aging infrastructure and how do we support hospitals that want to continue to serve their communities, but maybe do that with a different delivery model. We do have a pool of funds in Illinois, $150 million that will be allocated to support that effort. But the regulatory compliance issue is always a challenge in Illinois, and I'm sure in all states across the country. And we do have a little bit of flexibility with aging infrastructure until there's either a change of ownership or a decision made to close the facility.
So just follow-up question, AJ, with regard to certificate of need. We in Indiana don't have it. Do you perceive that as a barrier to your state and to your healthcare providers as opposed to Indiana?
Yeah, so it's interesting. We have 212 hospitals, and the majority of our hospitals, while they don't always appreciate the dysfunction of our CON process in the state of Illinois, about 70% say they want to keep it, even though that means that they have projects that might be denied because we have a board, right, that makes a decision based on need, and there's a whole rigor around that and analysis about a bed need in a particular community with a particular project. So I would say some are very much against keeping CON in Illinois, but the majority of our hospitals want to keep it. And I think the main reason is because they're concerned about outside folks coming in from the outside, right, from outside of Illinois, building a hospital or a facility in an affluent area that will lead to some cherry picking. So that's always been some of the rationale, that better to have that regulatory structure in place and kind of make sure that there's a need before a building goes up or a hospital is built that could impact existing facilities and hospitals in the community. But it's definitely not, it's a mixed bag within the hospital community, and it does create some barriers. And I think most of the hospitals say maybe some of those barriers aren't all bad.
And AJ is also a recovering state senator from Illinois, so he would have the public policy angle as well. But before I worked here in Ohio for the last 8 years, I was 15 years in Iowa. And one of the things, Iowa is a CON state and Ohio is not. And one of the things I feel like I learned, at least from those two states, is from a state legislative standpoint, whatever you don't have, you're quite sure that the other is the solution. In Iowa, they were quite sure that if we did away with CON, we would solve a lot of problems. And in Ohio, it's just the opposite. there are legislators who feel like maybe we should usher that in. So it is a difficult kind of set of dynamics when you talk to members or legislators about what the right answer is with that policy.
It's come up here. We're not a CO1 state, as my chairman, Rob McClellan, mentioned, but as he knows well from his involvement in leadership of the association, it is something that we've addressed or that we've dealt with over the past couple of years in our legislature. And I think the call for it has faded for now, but I think it's Mike said that, with his experience, and his experience is always very, very helpful. I think we're seeing other states like that, and Mike mentioned his time here in Indiana, that kind of grass is always greener effect that people have in public policy. So I expect it'll come back here, but I would just say maybe even to for this group, it's just something you need to be engaged in. If you're in this industry and you care about it, you may have experiences, of course, working across the country. So I would just, encourage you to stay engaged with your hospital association, be engaged politically, because the consequences of public policy certainly, impacts the delivery of healthcare, but also all that you do too. So, hard to say exactly what the best model is, but there certainly are differences in how it plays out.
Mm-hmm.
Well, this next question is near and dear to my heart because we as Good Samaritan Hospital is kind of fiercely independent. We're a standalone hospital for 110 years. And so my question relates to how does the long-term trend of healthcare providers forming these larger systems and these larger organizations, how's that impacted the design and construction of facilities? Does it provide additional opportunities because of the funding, or through access to capital, or has it created some restrictions?
Who wants to go first?
Well, it's funny. I think that's a question I really look forward to learning from this group about. That might be something I ask you guys, but I suspect that there are many hospitals that will find that it does, that associating with the system does improve their access to capital. Just looking across our state, I mean, we have very, very large systems like the Cleveland Clinic. Bon Secours Mercy Health is headquartered in Cincinnati and now in 7 states. But I think it's also kind of changed the nature of the facilities that they are requiring. And it's not just the consolidation. Was it Walgreens, or I think it was Walgreens, that said they wanted to change the front door to America's health system. So there were 10,000 new front doors to America's health systems. And I think, the large systems and the independent hospitals are looking at what is the customer-friendly way that we want patients who need high-quality care to experience us. And you are seeing the building of micro hospitals and freestanding emergency departments that are very valuable, that are providing great care, but they do kind of, change the chessboard a little bit. So the whole consolidation that is very, very present in our state. We are seeing independent hospitals that view affiliation with large systems as an absolutely kind of seductive path that they will consider. And we are seeing others that wouldn't do it for all the tea in China. So, and they are very successful, so they don't require that. But it is kind of interesting when I, come to work every day and get the courtesy calls from people who will say, hey, I just want to let you know, we're going to announce that we are affiliating with this. We have a hospital on the far east side of our state in Barnesville that affiliated with West Virginia University. So, we're seeing, when I first got my job 9 years ago, we saw very large systems acquiring smaller hospitals successfully for both parties. And now we're seeing very large systems acquire other very large systems. And that's just, kind of a very real dynamic that's going on throughout the country and through, I'm sure, all 3 of our states.
Yeah, and I can add to that with the Illinois experience. It's interesting. We have both models, right? The system model and the independent model. And a hospital close to my home where I receive care, my family receives care, fiercely independent and want to continue in that independent model for many, many years. And we applaud that. And then we have systems, large systems, as you know, in Illinois, like in Ohio and in Indiana. One of those large academic systems has, over the last 10 years, gone north into the suburbs, northwest, western suburbs, and really has developed a pretty large health system in the Chicago market. They just recently announced acquisition of a hospital for the first time in the Southland area, so south of Chicago. And then they just announced about 2-3 months ago, they're building a 75,000 square foot ambulatory center in the near south side of Chicago, which has traditionally been an underserved community. And so we have this large academic system, well capitalized, moving not only in the northern, northwest, western suburbs, but now in the Southland, Cook, and building an ambulatory center in the city of Chicago in an underserved community. So I think that's a good example of where a system can leverage their access to capital and their strong balance sheet to create opportunities for additional facilities like that ambulatory center, in addition to acquiring hospitals. And I think the idea is to build on their brand and expand their scope so that brand can travel throughout the Chicago region and attract more and more patients. So that's just one example, but I think that example is reflective of what we've seen with other systems. We have a central Illinois system that has actually come into the Chicago market and acquired a hospital in the on the southwest side of Chicago. So it's not just the Chicago systems becoming larger by acquiring independent hospitals within Chicago. We're even seeing downstate systems coming into Chicago and acquiring independent hospitals as well. That all will continue, and I know we have a follow-up question about the multi-state, which I look forward to discussing as well.
I would just say that similar trends, but I think Mike put an interesting spin on it, that the change that's occurring and how it impacts the kinds of projects or the way that hospitals are thinking. It's not just about whether you get bigger or align with a large system, which can create access to capital to be able to do projects in underserved areas. So that can certainly help. That's difficult to do for someone to just do as a standalone, because it's likely to not be feasible by itself. So you do need some scale, I think, to be able to continue to reinvest in underserved areas like that. But it isn't just about the change within the industry. It's, as Mike said, it's about the other actors, the retail players in healthcare. So I think that's brings a whole another degree to it. So hospitals, I think, need to think not just about getting bigger or becoming part of a system in terms of access to capital, but maybe partnering with some of those other players as a way that they can compete with, whether it's traditional health systems or some of these new entrants. And what does that look like? I mean, I do, Mike mentioned it. We're seeing that here too. Some of the micro hospitals, urgent care centers. One of the kind of lessons from COVID early on seems to be that emergency room use hasn't bounced back in as quickly as maybe some other services. So, have people started to use urgent care and telehealth a little bit differently than they did before COVID? So how does that influence what people build and think about going forward? I think there are lots of different factors, and systemization is only really just one of those that's at play.
Well, to follow up on that, and Mike had touched on it, and then AJ mentioned it, but the follow-up question really does relate to, and important to me, because Good Samaritan is right on the Illinois border, and how that impacts our hospital. What does the future look like from your perspective in this tri-state area with respect to systems becoming more multi-state?
It's definitely a dynamic in Ohio, and it probably is elsewhere. I mean, like I said, Bon Secours Mercy Health is headquartered in Cincinnati. They have hospitals all over our state, and they have hospitals in Virginia and the Carolinas and Florida. McLaren which is headquartered in Michigan, bought a hospital in Northern Ohio. Beaumont, the largest system in Michigan, originally announced with Summa Health System in the Akron area, home of the Pro Football Hall of Fame in Canton, that they were going to acquire, and then that was scuttled. They're not acquiring that anymore. There are rumors every time, there is a negotiation in our state that UPMC is involved with that. So, we think, UPMC has interest in being here. So I do think that is a very real situation that we're just going to have to deal with. A lot of the traditional multi-state systems in the country are for-profit. And we have a very small for-profit presence in the state of Ohio. Only 3% of our hospitals are for-profit here. So, but I think we're seeing a lot of the not-for-profit systems also, going outside of their traditional state borders.
I've seen a lot just in my time at the association, just over 10 years, 12 years now. And that, I think AJ mentioned this earlier, the trend when I first started was just actually kind of starting to abate a little bit. And that was largely Indiana-based health systems affiliating with critical access hospitals or other formerly county hospitals throughout the state. Rob remembers this time well, a lot of affiliation there. And that's kind of changed a little bit in the sense that it's slowed. And even in some cases, there's been a realignment of some of those partnerships, much more geared around natural markets, I guess, one might say. So we're seeing that today, just last week, I think it was, one of our hospitals in Southern Indiana has announced that they're exploring a partnership with Norton, that's King's Daughters Health in Madison, Indiana, and they're closer to Louisville than they are to Indianapolis. That's where patients go. So for us in Indiana, as the Indiana Hospital Association, it does mean we're kind of working more closely with our colleagues on the other side of the border because we have more and more joint members. And I think that's just going to evolve around these markets. When I started, there were some hospitals that were managed by Louisville-based health systems. And now just in the past couple of years, the county hospital in Floyd County, Indiana, down in the sunny side of Louisville, as we say in the Indiana border, that they've now part of Baptist Health, St. Elizabeth, another Kentucky-based system affiliating with High Point Health, our hospital in Dearborn County, Indiana, and in Indiana, South Bend, Beacon Health System in Northern Indiana recently announced that they're affiliating with a Michigan-based hospital. So what it means is I think that, again, we're just seeing state lines, which are a bit artificial in a way with respect to patients, mean less as far as what growth looks like, and maybe more of these natural markets. That kind of shuffling seems to be happening. And I think, Rob, you've seen this a little bit in Southwest Indiana too, right? I mean, your office, I think you can see AJ's domain in Illinois out your window, right? So
I can skip a rock across the Wabash to get to him. Yeah. You just see more and more opportunities where hospitals, even the size of Good Sam, which is reasonably small in comparison to others, have been able to reach across the state lines and be able to work with smaller hospitals like Lawrence County and Richland and others. So I think you're going to see more and more of those opportunities. And certificate of need, I guess, AJ, from my perspective, hasn't been a terrible distractor for us to be able to go over there and work, because we're not really looking to build structure right now. So that has been a reasonably positive thing. Maybe it impacted us a little bit from a home care standpoint and a hospice, but otherwise it hasn't been a big deal. So.
Yeah, that's good to know. And, real quickly in Illinois, we have Advocate Aurora Health now. Well, 3-4 years ago, it was Advocate in Illinois and Aurora in Wisconsin. Right. And they just come together, 28 hospitals, 70,000 employees. And then recently they looked to expand and create a 3-state system by bringing in Beaumont Health from Michigan. That fell through for various reasons, but it's clear Advocate Aurora is not going to stop. looking at opportunities, and those opportunities are likely to be beyond the state of Illinois. So it's just, and the state of Wisconsin. So that trend will continue, I think, in Illinois and in the region.
Well, and looking west, I mean, back to my old stomping grounds, Unity Point in Iowa came very close to merging with Sanford from South Dakota. So, I mean, there are deals like this kind of being discussed all over the country.
Yes.
Let me switch gears a little bit. Up until now, sustainable design and environmental impact have been kind of an increasing area of focus. But with the lessons from COVID, you see flexibility as being one of those major goals in design. For example, the ease with which a standard patient room might be converted into an ICU, or having to expand your ED and being able to utilize vacant space or utilize a neighboring administrative office to be able to convert some of that. Are you seeing that?
I think yes. I mean, we're seeing the real need to be pretty nimble in terms of how you use the space, and we are converting certain areas of the hospitals to ICUs now in the state of Ohio, just because our numbers are so horrible right now. Our COVID numbers are so terrible. But once we get through this, and presumably we will, I envision that, as I said earlier, we will probably be looking at infrastructure that needs to support a lot more telehealth and doing things outside of the traditional setting. But that has not quieted the interest in our state for building the more traditional bricks and mortar. But I think, negative pressure and all the things that are required in the situation that we have now, I think is going to really invite a lot of innovation and creativity on the part of the people who have that skill set. So yeah, I think we'll see a lot of that.
Yeah, we, from where I sit, and especially lately with kind of the statewide policy focus that we've had in terms of surge, I haven't talked to as many members directly myself. But just in talking, I reached out just to get some feedback about what people are hearing, and to some of our strategic partners, and Ross and Berezini, who's one of our partners at IHA, just to try to get a sense of what's out there. And it sounds like, flexibility is the watchword. I think people are really thinking about, look at the lessons of COVID. We've been up and down how many times already. Mike mentioned telehealth. We thought that telehealth was going to kind of take root more strongly years ago, and it didn't. And it seems like it has now, but is that permanent or not? So I think from what we're hearing as people are designing space, there's lots of considerations, but nobody knows exactly what healthcare is going to look like. It's going to get back to some sense of normal, but preparation for another pandemic or another event, I think is higher at the top of the list. So people are thinking about flexibility kind of almost over other things. Now, maybe that will change a little bit, but like I said, from the folks at Ross and other members who have kind of shared, they're already right now, ripping up space and trying to adjust with existing infrastructure. So I think as they go forward, they're going to look to see how to be able to convert emergency rooms. Even though other volumes were back, emergency rooms still seem to be low. So is that going to be a permanent trend? Do we need less capacity there? Do you need a space that can kind of maybe flip more easily back and forth between urgent care and emergency room, and have some greater flexibility just in that space alone? ICUs, you look at how quickly the industry and what a tremendous job. I think, we're all equally proud of our members who have just done amazing work to scale up and create new critical care beds and be able to place vents. I think anyone looking at a new facility is going to say, okay, have we built into this what that surge plan looks like in a way that's probably more intentional than ever?
Yeah, I think that's well said, Brian and Mike. And the conversion experience under COVID certainly has us all thinking through, okay, what does the future healthcare delivery system look like in terms of the access points And is there going to be another pandemic? And if so, let's figure out design that's flexible so that we can have those conversions done more rapidly and with more convenience. The other piece, telehealth certainly, and then home health. A lot of talk about home health as well. So what does that mean? Telehealth and home health obviously not provided within the four walls of the hospital or even in an ambulatory center. So all of that is in play, and I think a lot of the lessons that, some of this discussion took place before the pandemic, but certainly the experience of the pandemic, especially around that conversion to enhanced capacity, really key takeaways, flexibility and convenience is certainly.
Are you guys seeing your hospitals go back to 2 beds per room?
Yes.
We're seeing that, however, temporarily here, just out of staffing needs and space needs. But
right. We've done that, and then we've had some hospitals say they've taken their, of course, med surge, turn those units into ICU, but also creating med surge units in lobbies, right? That one hospital that I talked to about a week ago has had that experience. I don't think they're unique. Now we know these are extraordinary circumstances, but it is illustrative, right, about where we're going with care delivery and how we need that flexibility. No question.
I know from Good Sam, we finished up a $140 million building program where we had all new inpatient units in July of 2015, thinking we were done. Perfect. We didn't have to touch anything. We are now having to go back and convert a lot into negative pressure rooms that we would have never comprehended needing. So Don Page oversaw all that, and he's working right now on our ER, on our OB unit, as well as our critical care areas to just add more permanent negative pressure rooms that we would have never, prior to this pandemic, envisioned having to do. So there's a lot of adapting needed even on the new stuff that we never expected to have to touch again. All right, next question. Up until now, with the 2020 election kind of behind us, what do you expect from Congress and a Biden administration on healthcare policy, and how will it affect the membership?
Yeah, so I'll take a first stab at this one, and I think there's 2 priorities from what I've been reading and hearing. Right, there's the COVID work that needs to be done on day one, and then the other priorities of the Biden administration that he talked about. So on the COVID category, of course, he's going to keep Dr. Fauci engaged. He's going to join the World Health Organization, and he's going to move forward, hopefully, with a very coordinated vaccine distribution plan that is already underway. Thankfully, transition discussions are taking place. So there's a whole body of work around COVID, and then there's other priorities that the president-elect talked about on the campaign trail. For our purposes as a hospital community, we know that he wants to strengthen the ACA. It looks like the Supreme Court may uphold that law that was passed in 2010. So we need to address some of the flaws. The premiums are very high. It's become unaffordable for many people. We certainly support those efforts. And then when we think about the Biden administration and looking at the public option, will he be able to move that forward? It appears that Mitch McConnell will still control the Senate, although that's not certain given what's going on in Georgia. But I think that'll be a little bit of a stretch and a lift to move forward with a public option, although he campaigned on it. I think he's going to have an aggressive labor agenda, which, can be challenging for the hospital community. And I think he's also going to want to move forward on health equity priorities, such as maternal morbidity and maternal mortality. And these are areas that we certainly want to work with the new administration. We're having those conversations in the state of Illinois around health equity, especially given the experience of COVID in Illinois, and we've seen the disproportionate impact that COVID-19 has had on Black and Brown communities, and the need to really take a hard look at how we can advance health equity and eliminate health disparities. I think the new president is going to be very interested in moving forward with that type of an agenda, and we're certainly looking at that in Illinois. So those are just a few thoughts about the new world order after January 20th.
I would agree with everything AJ said, and I do think that, politicians tend to favor incrementalism when it comes to public policy as opposed to giant dramatic steps, despite the fact that, their speeches might suggest, giant steps. I think we are more likely to see incremental improvement and change. I think this industry that we all love and we're privileged to work in, I don't think we do a great job of owning some of the problems that we really should work to resolve so that politicians don't cram bad ideas down our throats. And I think, one of the things we need to confront is the price transparency issue, for example. And it feels like, we have so many bad ideas at the state level and the federal level about how to do that. But my frustration, and I'm criticizing myself on this, is that we have not delivered that better for America. I mean, I don't think that it's unreasonable what they are requesting, but due to the complexities of our relationships with payers and various things and the complexity of the services we provide, it's not easy to resolve that. But I do think we're doing a better job today than we have in the past. And I would say the same thing about affordability. I mean, if we look at some of the work or some of the articles in the Wall Street Journal that have reported such a small amount of savings that most Americans can lay their hands on, and we're sending bills in the thousands of dollars to people who have no hope of settling up with us, how are we going to address the affordability problem in this country before politicians, very properly motivated, send a raft of bad ideas our direction that we have to fight against? So I think that I also agree with AJ that I think we all need to be very, very interested in Georgia. I think what happens in those two Senate races will be really telling in terms of if the Democrats control the House, Senate, and White House, that could actually be more difficult for President Biden than if at least the R's control something. That way, it can maybe force a little bit of compromise. But yeah, I think it's going to be really interesting to see what happens with both of the Senate races in Georgia, because I think that could have implication for how we work in DC.
Well, and that was my follow-up question, whether your answers change depending on those last two seats and whether the Democrats control all three branches, or there's a little bit of gridlock involved by having some of the Republicans control some.
Well, they're going to be close majorities regardless. I mean, the House majority is very slim now compared to what it's been. And, there'll be challenges on the horizon with having, the party in power tends to lose seats in those midterms. So it's not the strong majority that they've had in the House for the last couple of years. So that changes the dynamic there, even if the Democrats were to pick up those two seats. There's not a lot of room to spare there to be able to push, a really aggressive agenda in the way that I think some activists and those on the further left will demand. It just, the votes won't be there for some of that radical change. So I think the incrementalism, and Mike said, well, some of the incrementalism it's really important stuff too. It's some of the things are the things that people really care about. I thought about surprise billing when you were saying the things that we need to do within the industry. Unfortunately, that sometimes tends to devolve into kind of finger pointing between, oh, it's the docs, oh, it's the hospitals, oh, it's the insurance. And we've got to solve a problem like that and bring solutions to policymakers so that we can clear the deck of some of those things that shouldn't be partisan or shouldn't be really difficult issues, and then focus on, how we expand coverage in a manageable way, in a sustainable way that doesn't, really destabilize the existing healthcare system. I mean, we can get to some of those big ticket items, but there are definitely some topics that are, I think, do harm to the industry and kind of do harm to our cause for those bigger things that we want to solve, because they just have languished. They seem intractable. But something like surprise billing, which was a priority for the Trump administration, I think there's some executive orders even that were put in place. But that would be something that I think could be addressed on a bipartisan basis. And I hope it is, because it would really, I think, also alleviate some of the pressure sometimes we feel at the state level to come up with 50 different solutions across the country that that actually add to the complexity that all of our members face on a day-to-day basis. Typically we don't like national solutions. I think state solutions in general are usually better, but on something like that, I could actually argue it the other way, because I know we've all been dealing with different variations of price transparency bills and surprise billing laws and others. And so if we really want to kind of create some simplicity and get down to core things like sustainable payment for services, how we expand coverage in a meaningful way, we got to clear the deck of some of those thorny issues.
What's the impact of the census likely to do for 2 or 4, both of your congressional delegations? We're likely to lose one member of Congress from Ohio.
I don't believe we are likely to lose a member this time. I think it's more likely the projections that are out another decade have us losing a seat then.
We lose a seat. We go from 18 to 17.
We go to 16 to 15 from 16.
We're only at 9, so I think we're going to hold steady, I believe, this time.
All right, just a couple more quick questions. One, at the state level, so this is kind of for each of you individually, what are the top healthcare agenda items for your association, and what are you watching with respect to your governor's offices and state legislatures?
I'll defer on this one because I know, Rob, these gentlemen have a hard stop, and you and I are going to do a little deeper dive into Indiana. So I'll let them talk.
Well, real quickly, we talked about telehealth and health equity and healthcare and hospital transformation. A lot of key issues for the managed care organizations, the Medicaid and HMOs, and their practices of deny, delay, and dispute. So we have all of that. But we have to say, in Illinois, it all starts with the budget. And we have a $5 billion budget deficit we're staring at starting July 1st. We're underwater in our current fiscal year. I know you guys are shocked that Illinois' budget is a mess, but it is. And it's even messier than it has been for the last 30 years. So that's first and foremost. Medicaid is very, very vulnerable when you are staring at a $5 billion deficit starting July 1st. So I'll stop there.
Well, one of the reasons we all love AJ is because after AJ speaks, none of the rest of us feel like we really have any problems. But I will say we have the same issue. I mean, when Medicaid was a tiny portion of a state budget, you could hide, but you can't hide anymore. It's half of the state budget in Ohio, and there's nowhere to hide. So we are looking at trying to solve the state's Medicaid problem with them. We have a great relationship with our executive branch, trying to look at some of the MCOs and some of the places where they need to go if they want to run a really super efficient state Medicaid program, but all the while trying to protect our rates. So really, we have a 2-year state budget like Indiana does. So this is a budget year for us, and we're going to be just really rowing very hard on helping put the state budget together in a way that is not punitive on hospital Medicaid rates.
All right, got 1 minute. I want to get one more question since AJ and Mike are stepping off. How do you guys, as association presidents, work with each other to kind of bring value to your members, even between states?
Well, that's one of my favorite things to do. I mean, literally, there are people I did not know before I had my job who will now be lifelong friends. And there are people who have retired like Doug Leonard from these jobs who, vacation with the people who were their colleagues for their entire careers. So the 3 of us and others spend a lot of time on the phone with each other, asking questions that are gigantic, bigger than life, and also asking questions that are important but relatively small, bureaucratic, and how you run your organization. So we share a lot of information back and forth, and I think it's one of those where what is the phrase? The sum of the parts. The whole is greater than the sum of the parts.
Greater than the sum of the parts. Yeah.
But I think that together we really I think make each other better leaders.
No question. I would echo everything Mike just said. We talk about issues that are important to us in our professional capacity as leaders of organizations and and supporting our hospital membership from policy issues that we just discussed in this last hour to operational issues. How do we make sure that we show the respect and gratitude and appreciation for the staff that do such amazing work within our organizations, to just being a support system for one another, which is extraordinarily helpful. And so it's a great experience. It's definitely one of the highlights. And I think, to Mike's point, we are all better at serving our membership because of that camaraderie and support.
Well, gentlemen, it's 11 o'clock, and I know you've got well, 10 o'clock for one of you. I know you've got other things going on, and just wanted to thank you for your time and your honesty and just your knowledge of healthcare in the states that you guys are so blessed to be able to work with. So we wish you all the best.
Thank you.
Thank
Go
you, Rob.
Hoosier.
Well,
Great to see you guys.
thanks, Brian. See you, Mike.
Bye.
And with that, Brian, I'm gonna turn it over to you to talk a little bit deeper on the state of Indiana and all things Hoosiers.
Well, thanks, Rob. Just to kind of follow up, my responses to some of the great questions that you asked there at the end. I wanted to let my colleagues share, but just to echo what they said about how important it is. We recognize that many of our members now, as they expand across state lines, it's important that we look to provide value. So increasingly, we're talking about how we can find efficiencies and work across state lines on various projects. Mike mentioned concerns about Medicaid. So when we're looking into say, okay, how do we, who's got a good way or a good method for analyzing our Medicaid shortfall, for how are you collecting information from members? How are you operationalizing that? What's your strategy for getting public policy change? We share information like that all the time. And really through this year with how we've responded as associations to try to help our members, that collaboration from across the states has just been invaluable. And I want to credit the American Hospital Association, who helped support us while we're all individually different, kind of standalone organizations. We all work together, and the AHA has pulled us together, often all 50 states and more, with DC and Puerto Rico and others on some of those calls at the height of the surge, to say, what's working? What have you found out there? Tell us the lessons. I remember hearing from my colleagues in Washington State about the early surge when we knew so little about COVID, and it was just, running rampant through some of the congregate living facilities. We unfortunately, I hate to say it, but we learned from some of the pain that they endured. And then we continue to talk about things, what are you doing with your governor? What type of restrictions have made a difference in terms of slowing the spread? So we do that all the time. And I think we're going to continue to do it really increasingly because of some of the systemization and the growth of healthcare entities across state lines as they align along regional markets. And those, AJ and Mike, are just two outstanding individuals. So I'm privileged to be able to get to work with them. In terms of what's on the agenda here in Indiana, I just kind of wanted to share a little bit. I do think it's somewhat similar with some differences. So telehealth is probably the number one topic that we have on the agenda, because it's not just our priority, it's shared by many that we work with. So our community health centers, the physicians, we are all looking to kind of come together about how we can align and work together to make Indiana more open to telehealth. And at the same time, there are other groups that have telehealth in mind, but are also looking at the impact of COVID, and what it's driven home is not just the need for bandwidth and telecommunications and broadband infrastructure to access healthcare, but for businesses and education. So I think there's going to be a lot of talk in Indiana, not just around the rules and regs on telehealth, but even a broader discussion of how we really invest in a state in the pipeline, in the broadband, to be sure that everyone has access to education and healthcare, whether we're in a pandemic or not. So I think that's going to be a big topic. I think we'll hear from probably Farm Bureau and other groups, local government organizations, about broadband and how important that is. So I think that's one topic that will be high on the legislature's agenda. Last year, and we touched on this a little bit in the discussion, there was a lot of debate around healthcare cost. And there were a number of things that were thrown at hospitals, some legislation that was, quite frankly, anti-hospital. And it was a challenge. And we were able to defeat some of the most onerous provisions. And I want to credit you, Mr. Chairman, and the other members of the Indiana Hospital Association. We really had to step up and educate lawmakers on the unintended consequences of what some of these proposals were. I think there were some legislators that once they learned about the impact on their local hospital, realized that this would limit access, this would hurt healthcare delivery in their community, and we were able to turn the tide. So again, I mentioned this earlier, I would just ask everyone, all of you that work in the healthcare industry, to educate yourself, work with your hospital association, consider yourself a stakeholder in the health and future of the industry, because there is a big spotlight on it. There are a lot of battles that are taking place, and we need partners. We need allies of healthcare to help us tell the story of what we've gone through in COVID, but also how we're trying to transform the industry. And we need to make sure that harmful policies don't derail us from the important work that needs to be done to recover from COVID and really transform the industry. So, in addition to pushing telehealth forward, I think secondly, we're going to, need to make sure that we don't have some of those harmful or concerning proposals come back here. So those are really kind of major priorities. And the budget, of course, mentioned Medicaid. I think Mike spoke to that well, so I won't mention that, but that's a priority as well.
I think one of the things, Brian, that this group ought to hear is how important they are, as you mentioned it. I think the ASHE members do have an opportunity to have a voice and be an advocate for appropriate change and adapt, because this is not just left up to the hospital association members. It's not just left up to CEOs. This needs to be every single individual within the organization, professional in nature, that can have an impact and have a voice to try to affect some positive change.
Yeah, that's right. And I think it's really important sometimes, it can be more important to have stakeholders like some of the folks that are, I think in the audience here and others who can bring a different perspective and help educate policymakers on some of those unintended consequences, because it's unfortunate, but sometimes in the heat of battle, what happens with legislative action is there can be finger pointing, and you may have one group on one side, disagreements with like the insurance industry and hospitals on another, and there's sort of some back and forth here. And often what's needed is another group, businesses and others, to come to the table and say, look, there are some ways that we can address this transformation, these changes that are needed through contracting, through delivery reform. There's other ways to kind of skin the cat. We don't need legislation, or we don't need legislation that does this, or maybe we do. I mean, one other area I think that where we really need the help of the business community and healthcare stakeholders is to say this year, this is also a legislative priority that I should mention, which is to look at something like the tobacco tax. We're seeing the toll of COVID, and the numbers for Indiana are grim. They certainly are elsewhere, but I think what's starting to be revealed now over the length of this pandemic is that our health metrics, our health condition as a state, makes us perhaps more vulnerable. Not perhaps, it does make us more vulnerable to the impact of COVID. So I have heard legislative leaders and others say that next session we need to also look at what we can do to improve the health of Hoosiers, which is really important as well. And that's something where I think the voice of business can really be powerful, to say that, tax increases are not someone that, typically you get a lot of support for. But here in Indiana, the Indiana Chamber of Commerce has been a strong supporter of raising the tobacco tax because they know that it will not just make Hoosiers healthier, but also lower the cost of businesses for their healthcare premiums. And it's just the right thing to do for the long term. So again, for all of you to just be engaged with advocacy in all of those areas, I think is really, really helpful.
Last comment, maybe for you to dive in just a little bit deeper, is just some of the things going on from a COVID response standpoint, and maybe a little bit of the focus the Hospital Association has had in working closely with Dr. Box and with the governor, trying to hopefully provide some steerage and some professional advice that will be helpful to the state as we go forward.
Yeah. So with that, could I, Dave, I wanted to share just a couple of slides. All right, how is that? Can you see that?
Yep.
All right. Well, just to sort of level set and let you all kind of know where we are. And I know Don said at the beginning that you know, we're tired of COVID and I don't want to do a deep dive, but the reality is it does overshadow and influence really everything we're talking about, even if it's a non-COVID topic. The timing, strategy, and everything else around it is influenced by what is before us, and the numbers are stark. And so here is, as of yesterday, I don't believe this has the current numbers that will probably be released here soon in Indiana for hospitalizations. And these are COVID hospitalizations. So there are many, many patients in hospitals like Good Samaritan and others that need care for their heart attack, their stroke, other conditions, not just COVID. But this gives you a sense of how significant the crunch is because of these rising trends. So all the way back in the spring, when this data was first being collected, you know, we might say that that was our first surge. And there's kind of a sense out there that we're seeing a second wave that maybe it's in some ways similar to the first wave. And I'm certainly, there are things that are better, and there are even more better things around the corner. We know that vaccine distribution will begin soon. We have new drugs and therapies to treat COVID. We've learned a lot about just techniques, and so some of the lengths of stays are shorter, and there's some good news kind of hidden in there. But this wave is also so much more significant in terms of the impact on hospitals today because of the sheer number. So the blue line, the blue area really represents those positive COVID cases. And you can see the gray line is what we call PUIs, or those that are just suspected of having COVID, but many of them are ultimately ruled out. And so that number has actually declined a little bit over time as testing has gotten more robust and we're able to assess COVID much better. So if you just looking at the blue line itself, how many more patients today? Almost yesterday, it was up over 3,400. I think it was almost to 3,500 patients with suspected and with COVID. So the sheer number is dwarfing what we had in the spring, and that's just made the strain very difficult. And what is different about this time is that we had in the spring essentially a complete shutdown, as we all know, of really the economy, but including elective procedures. And I know, Rob, we've shared this with policymakers recently that, you know, that's the last resort. We do not want to go there as an industry because there are many people that still need care that was deferred back in the spring. Or in other cases, there are experiencing symptoms and conditions that because of deferred care, so they require a longer stay, or they need ICU level care, whereas maybe if they had gotten something taken care of, it could have been handled maybe even outside the hospital. So if you overlay this with what we're seeing kind of from, really it's influenced by COVID, but it's the broader hospitalizations, it's really challenging for staff. And I just want to mention this because I try to do it everywhere. And for those of you, thank you. And to Don and your colleagues and others that have been doing all the Herculean efforts to reshape your facilities, to those, overseeing infection control and everything else that's going on in our facilities. You are heroes, standing there alongside our nurses and our physicians. You've been fighting COVID tirelessly since the spring, and we appreciate it. But we know that this toll is just, it's difficult. It's difficult. We are scrambling for staff across the nation. It is in the headlines. I'm sure you've heard it. I may ask Rob just to kind of comment in terms of what they're seeing there at Good Samaritan. But this is, again, one of the differences between the spring and now is in the spring, we're still learning about COVID. We didn't have PPE. The challenges were different. Now we've got these rising numbers, but really a decreasing number of staff because people are tired. They're quarantined because they've been exposed in the community. They're having trouble with childcare because schools have moved to a virtual format. So there's really a perfect storm that is impacting the supply of the healthcare workforce at a time when the need for care is rising. So, what we've heard is that this is starting to inflict more financial pain on the industry because of the costs associated with trying to fully staff a hospital now to deal with not just COVID, but all of the needs of patients. And it is a challenge. And I would say right now, the reason I wanted to spotlight staffing is because it is probably the number one concern that we have, and it's not an easy one to solve. So I'm going to stop my sharing now. I'm going to go away.
It did go away.
All right. And so, Rob, I don't know if you just want to comment if that's similar to what you would say is your main concern at this point and going forward.
Yeah, I think from my perspective on a small hospital, when we shut everything down in March, actually March 18th, which will never ever leave my brain. I'll remember that day for the rest of my life. When we shut everything down at that stage, we were actually at a point where we were seeing 3 to 4 COVID patients max and nobody on a vent. And I'm rolling my eyes through the whole thing going, what are we doing? We are destroying this hospital and we're destroying healthcare. And now, within the last 30 days, we are now seeing 40 COVIDs on the inpatient side and 8 to 10 potentially on a daily basis on the vent. So it was late to get here, but it is fully here, and Southwest Indiana is just getting hammered. And one of the things that has been, I just don't think we could have planned for, regardless of what we did, was the staffing that Brian mentioned. And we're in the middle of that. We're probably 45 nurses short, whether it be COVID related or whether it be I'm burnt out to the point I can't do this anymore. And the answer of, well, let's just go with locums nurses. Let's do traveling nurses. I've been in this organization for 28 years and we had never used a traveler until the last 60 days. And it's not financially sustainable. And they're not available even if you could financially afford to do it forever, because they are looking at 5 times what a normal nurse makes. And the cost associated with that will vary organizations. And so we're struggling like everybody else. It's not really the bed capacity that has been the issue for us, even though half of my census on the med-surg side now is COVID. It's all about the staffing. It's about the nurses, the respiratory therapists, those people that are actually those frontline workers that are working on a daily basis with those patients. So it has been difficult, and we continue to work on it on a daily basis and shift our nurses from areas that are in the ambulatory and try to move them into an inpatient setting, but that's easier said than done. They're not designed to do that anymore. And so it's not like I can take a nurse that is in a family practice out in the middle of town and move them to the ICU. It just doesn't work that way, as you guys are fully aware. I do want to kind of follow up on Brian's comments on that one slide. I think you guys are the unsung heroes. I think engineers, plan off, and I think Don Page has already jumped off of this webcast, which is good because I don't want anybody to tell him that I'm saying something nice about him. But I will tell you, if it weren't for Don Page and his staff at Good Samaritan and the ability to adapt rooms at the drop of a hat, from regular room to negative pressure, from getting ICU beds access, getting the telemetry access, doing the things that you guys have done to get us ready for this is, it truly is amazing. And you guys should pat yourselves on the back because I know you don't get enough credit. And I know all the focus is on nursing and the direct care, but were it not for what you guys do and did, we wouldn't be able to accomplish the things that we have. And so I appreciate all of you very much because of that.
Oh, well said. I know. Boy, he really gives you the business. He's I don't know what he's got on you, but he certainly lets his CEO have it with remarks, but professional, but definitely a little feisty there. So, but no, and I think one of the things too with the rest of this audience, so both for those of you that are, the engineers that are doing this every day, again, thank you. And I think that we will really sort of look forward to, one of the positives I think that will come from the lessons learned is more innovation even. So I think working in partnership with those others that are doing design and thinking about what the hospital or the the facility of the future looks like is what kind of ideas can you glean, talking to ASHE members and others. So what did you do during COVID that you'd like to see as part of, I think there's going to be some probably just really cool and new innovations that come out of this. I think about, look at how much we've progressed in terms of the ability to treat COVID with proning and other things, right? So some of it is drugs, but some of it is just learning and how to use the existing resources within the hospital to treat this disease better, and how quickly, physicians were able to and nurses were able to figure that out. I think that a lot of the really neat things that folks in this audience have done to transform their facilities to care for patients, sharing that with each other and sharing that with those that are out working on projects, across the country, and disseminating that, sharing best practices. I mean, that's what these groups are all about. That's what we try to do when I convene with my colleagues, is what's working for you in Indiana. And, so I applaud you for taking time to do that with each other here. I hope this is helpful to you, but it is important. I know there's so many things going on, and it's hard to get away, to take that time to catch your breath and talk to your colleagues across the country, or, in the state, or even just in your own local market, to say, hey, what have you found helpful throughout this, and learn those lessons. It's going to make us all stronger and just improve the delivery system overall. So Rob, I don't know if there's any questions that have come in from the chat. I know Don's not with us. I don't know if there's anything Dave or anyone else would like us to address.
Yeah, I was monitoring and I didn't have any other questions.
Okay.
Yep, I think you're in good shape. I've seen great compliments coming through. Even Don was quite pleased with how Rob had performed, so that's always a good sign. And no, I would say on behalf of ISHE, this has been incredibly helpful. I appreciate the time that both you, Brian, and Rob have put into this, the coordination and preparation for this, and the information was really quite outstanding.
Well, thank you. Thank you. Thanks for the invitation. It's great to see Rob as my chairman, and throughout COVID, we are talking frequently.
We are.
Been multiple times already this week, but
I'll just finish up by saying thanks again to the panelists. It was pretty awesome to have. I've never been part of a 3-state hospital association president forum, and that's good. That's really good, and I'm proud to say that this came through ASHE, and Don Page had a little bit to do with that, so that's all good. I want to also thank BSA Life Structures for sponsoring the event. And I guess with that, I would wish everybody best wishes. Have a Merry Christmas. Let's hope for a much smoother 2021. I'm about done with 2020.
Well said. I also want to let everyone know that this session has been recorded. So if any of your colleagues couldn't make it, or if you wanted to see any of the information or hear any of the information again, it will be available. We will send an email broadly when that is available. We just need to finish the recording, drop in the BSA segment, and then we'll have that posted for everyone who wants to see it. Thanks again, gentlemen.
Thank you.
Thank you. Stay safe.